All right, we're going to let Kelly start it with some questions we received online.
Question number 1. With increased newborn screening, inexperienced radiologists are reading images. Are there increased higher, less scores, i.e. false positives? How often and how often do artifacts affect misreads in less scoring?
I don't know about the newborns and misreads. I think there are a few out there. I don't know if the rate is increased or not, but others can comment. The most common thing I see is that radiologists aren't familiar with the scoring system. So I got an email on a child who has a reported score of 24. When I got the discs, the score is actually 15. And that's just because they weren't familiar on how the system is to be used. That's the most common thing I see, is just lack of familiarity. I don't know about newborns and babies.
Yeah, so it's a very common problem on first MRIs that radiologists are over-reading MRIs because your white matter myelination is still incomplete at that age. And if you are not used to looking at MRIs of that age group, then they will be over-interpreting the normally developing white matter as abnormal white matter. So I think it's important to just, stay calm and send it to one of us.
But isn't that the reason that you started year 2.5? Because of that?
So I think that, yeah. So Stefan is referring to our consensus guidelines that have come to the conclusion to start screening at 2 years of age and on the MRI. That the problem still arises at 2, so you still have to be cautious because myelination, most of myelination occurs until 2. Some of it is still continuing, and there might be some delays and showing up as terminal myelination zone problems.
Okay, next question. Is there an algorithm that physicians will use to determine which patients should receive gene therapy based on donor availability? What must physicians and families consider when evaluating risk-benefit?
Yeah, I mean, there's definitely an algorithm. It's in my head. It's not. It's my algorithm. So the problem is all the different transplanters, they probably use a different algorithm of what they think the risks and benefits are. But that gets into the second part of the question, is what do families need to know? And there's just a ton of things they need to know. I guess the things I would ask are, at a given center, what is the rate of GVHD for the various products? Is gene therapy available? What are their outcomes in ALD? What is their graft failure rate? And those are the big questions I would ask. And then I talk about the fundamental differences in the products and the lentiviral insertion and all the things that are on the label. And there are a lot of things on the label, so it's a pretty long discussion over, not just one meeting, but a couple of meetings. But those are the big things.
Yeah, I guess I would just add that one of the first simple questions I ask is are there siblings? And having a sibling who doesn't have ALD and is a well-matched, HLA-matched donor might change this whole discussion very quickly. So, because we think there's really equivalence for gene therapy and having a well-matched sibling donor bone marrow transplantation.
For Dr. Kemp, what is the ALD range for VLCFAs? What is the range for the gray zone?
Well, I can tell you that for the C26 Lyso PC, the cutoff in our lab, not say it specifically because it depends which lab you're using, because it depends on machines, it depends on the techniques. So that's, I'm giving a lot of answers for one question. Okay, in our lab, the cutoff is 72. This is the upper range of controls. Yeah, 72. And yeah, the gray zone is as large as you have your lowest proven ALD case. So everything in between is the gray zone. And when I said machines, it's because for the plasma variant chain for the acid analysis, it's done in many different labs. And sometimes I get results, and then people think that I can do something with it. But my first question is, always, yeah, what's the machine, what's the technique, what's the reference range in that lab? That's the key information. That's the same with you, with your bone marrow transplant. That you have all these key questions. What are you doing? What is...
Next question. What are the psychological symptoms that occur in adult men with ALD? How can you gauge people getting worse?
Yeah.
So I think there is a distinction to be made first, whether an individual has cerebral ALD or not. We do know from publications that are now many years old that individuals with cerebral ALD almost the sort of the defining moment in terms of the clinical course is the onset of changes in their mental health function. It can be, you know, having to do with cognitive dysfunction, like executive dysfunction, so meaning having decision-making issues, judgment issues, or difficulty with complex tasks, or range all the way to mood disorders, rapid changes in mood, rage, behavioral outbursts, and so on. That's on the cerebral ALD side, well documented, and that's oftentimes the only way, if you don't have imaging, that you can tell that somebody has developed cerebral ALD, because they already have AMN symptoms, the myelopathy symptoms, and it's usually a change in mental health function, cognitive function, or behavior that is sort of the marker of cerebral disease. And we don't want to wait for that, because oftentimes by the time you have exhibit those symptoms, the disease is quite advanced. On the other end, I think specifically anxiety is very, very common in general in ALD, in men and women, and with completely normal MRIs. Anxiety is extremely common. I mean, anxiety is common in the general population. It's the most common mental health disease, I think. But it's probably 3 times as common in ALD. There is something we refer to as disinhibition, which means sort of lack of controlling, lack of controlling yourself, and we see that higher prevalence in individuals with ALD, even with normal MRI. One question I've always asked myself, and this is something we've always worried about, is there, in the boys we always know that the MRI changes will precede clinical changes. In the adults, we are not 100% sure that's really the case. And it's kind of a vicious cycle kind of question, because, for instance, we've had several individuals over the last 10 years who've had drug-seeking behaviors, drug addiction problems that preceded cerebral ALD. And it's always the question, well, is it the mental health change that is already part of the disease and we just couldn't see it on the MRI? Or is it that drug-seeking behavior itself is a damage to the brain that triggered the disease? So we don't know really for that. But that's where I would leave it at. I don't know if you want to comment on it more.
Can we take an audience question and then go back, if that's
And
okay?
one more.
Okay.
What percentage of gene therapy patients do you expect will develop MDS? And is it worse than graft versus host disease?
Sure. Well, the percentage. So right now it's 3 out of 51 total. We're about 60, so that's about 5%. But that's as of today. because it's a lifelong therapy, there's probably going to be a risk going forward. So it's going to be at least 3%, but it could go higher. That's just a guess. Is it worse than GVHD? That's an opinion question. And in my opinion, it's definitely worse than GVHD, because what we try to explain as transplanters is most GVHD in children these days, the rate is roughly 8%. So it's not a high rate, and 95% of the time it's treated with just steroids, and it goes away and doesn't come back. And so I try to convey that message during our counseling talks, is that it's out there something very scary. In the past, it was a lot worse, but our therapies for GVHD are much, much better now, and our rates are lower. For MDS, that's really only cured with a second transplant. And going through 2 transplants back to back is really hard on anybody. So I would say that that's actually worse.
So I have a question. So first, I just want to say thank you for all of the work that you do and all the research that you guys have put out. In the MS literature, there's just been this emerging phrase of building the neurological reserve and in early phases of diagnosis and taking advantage of neuroplasticity. Is that something that you would hypothesize, or that you could hypothesize would be applicable for ALD, namely in terms of like physical therapy and exercise?
I would just say we don't know the answer because we don't have any systemic way of telling that yet. Having said that, I would say we've seen it all. We have seen people who have been high functioning cognitively, physicians, neurologists. Not that we are the highest functioning physicians, but neurologists, lawyers who develop cerebral ALD. So I don't feel like high cognitive function or higher being really highly active is necessarily preventing you from onset of cerebral ALD. Whether exercise, healthy lifestyle affect disease course in AMN, I think yes, but again we haven't really looked at it, right? I mean that's the notion. There was one just brief mention is a study that Jen Keller did, which was an exercise study in women with ALD, where they went in and they got 6 months of extensive exercise. Oh, hold on, okay, why don't you, yeah.
There
3
she
months,
is.
right? Okay. Yeah.
They did 12 weeks at Curves Gym, and thanks. Okay. So we did a study with women with AMN and healthy age-matched controls, and they exercised a minimum of 3 times a week for 12 weeks in Curves gyms. Wherever they were located. They were slightly modified exercises so that they could do them if they couldn't do the equipment that's there. The group as a whole improved as much as the healthy controls in strength and walking. They just didn't get, if they were started off lower, they didn't necessarily get up to normal. We don't know if you keep going another 12 weeks if you continue to improve or not. So that's where but we could see the same amount of change in women with AMN as we saw in healthy age-matched controls.
Yep. Yeah, maybe just 2 quick comments. So in terms of neurological reserve, I mean, being higher functioning coming into any therapy, you're going to do better. And I think often we get these questions, is gene therapy better, bone marrow transplant better, or worse? And I think the biggest change has actually occurred in terms of just timing of treatment and us seeing huge advances just because the patients are caught so much earlier than a decade or 2 ago, and they were doing so well. And just maybe to add on to the whole MDS discussion, so far all children who've had MDS and gone through transplant have done remarkably well, and with no changes on brain MRI secondary to MDS. So I think that us getting early to the patients really helps bring all that neurological reserve out and harness all the potential. So, and then the second comment is doing physical therapy, integrating that into any treatment, I think over time is also going to be very important. We're seeing that some of the successes with other gene therapy trials with children really depends on how much physical therapy they're coming into the trial and also continuing right after. So I think that's really important.
Any other questions?
From
Online.
Zoom, this is a follow-up question from your talk yesterday, Dr. Lund. How do the healthy cells that could donate peroxisomes get into the target tissue? Is it still a stem cell transplant as the starting point?
The answer is yes. That was stem cell transplant to the recipient mice, and those cells engrafted at most of the organs of the body.
So something I worry about as an advocate and a parent is that, you know, there's so few of you that I trust to read my son's MRI. And, you know, more states are going to be testing and hopefully it'll expand beyond that. So I humbly ask, what are each of you doing to spread your knowledge and your expertise? Because I worry that there's not going to be enough of you as more patients come.
So there are far better people coming, and we are very lucky to have a lot of young investigators who are hungry and waiting to hit the ground. So our job is to train the next generation. So I think that's a huge focus of all of us here.
And we have one here today in the back, don't we? Another question here? Two questions. I saw his hand first. Yeah.
Has there been any sort of standardizing or procedure written down as pediatric patients transfer into adulthood and possibly move around that they can use as they enter adulthood?
I mean, so it's a topic of hot discussion in the transplant field now as our patients go beyond 18 and 21. In my world of ALD transplant, I still follow everybody as a physician because we don't have actually a good transition plan. If I sent them to an adult transplanter, they wouldn't really know what to do. But that is, it's not really the best answer. So I keep following them. Our endocrinologists, interestingly, have now transitioned patients when they're 19 to adult endocrine now. And that part of the plan is working, but it's not a complete plan. I don't know what other places do.
So it's a huge topic in neurology, and my nurse practitioner is actually very passionate about this and has given multiple talks about transition of care. And I think, you know, the adult neurology field is much less comfortable with genetic disease compared to the pediatric community. So I think that's another challenge. But we need to really come out with more guidance, and I'm going to have Katie write up what she's spoken about. So thanks for the pointer.
Yeah, I do want to comment on this because it's really reaching a critical point now in the disability world in general. Because you go through medical school and you go through training and residency after medical school, and you have no idea how to take care of somebody with disability. If you're an obstetrician, dermatologist, ophthalmologist, cardiologist, you have zero idea, but yet you have to take care of those individuals because, you know, anybody with any disability will still end up needing to see a dermatologist or a dentist and so on. And it's unfortunate because the push is, because there's so many specialties now, the push is actually away from, you know, getting that level of training during medical school and during residency. And so we are working with the American AUCD, which is the American universities that are sort of, there's a network for disability rights, and to try to really advocate to the American Medical Association and the ACGME, that's the association that regulates residencies, to bring into residency programs that are not related to neurology, training for how to sort of take care of individuals with disabilities. But it's a big process. It's going to need advocacy from all sides. It's a tough one.
Just to alleviate one of the last questions there about enough a neurologist coming in. Dr. Lund was introduced to me as a newbie when my son was going for transplant 14 years ago. And for somehow he hasn't aged or anything. I'm not sure I have, but he hasn't. And I mean, like I said, he was new and I was very skeptical of him.
I would still be skeptical of him. Just kidding. I love you, Troy.
I have a,
Okay, another question online.
could rickets in childhood be related to ALD? Related to vitamin D deficiency?
Vitamin D. I don't think there's an answer about the association between vitamin D deficiency and having rickets and developing symptoms of ALD right now.
I would say no.
Yeah, I would say no too.
Is there consensus or progress toward consensus on recommending antioxidants to AMN and ALD patients?
No consensus.
No consensus. Though, what I tell patients is that they're mostly all vitamins, and they can be given in healthy doses, but no consensus on them.
What are the long-term effects of taking daily doses of hydrocortisone? What are the long-term effects of taking daily doses of hydrocortisone?
If you are on what it's called like replacement physiologic dosing, you shouldn't have any side effects because we're just giving you what your body's supposed to be making. But that's why we monitor you closely. If you get like a dose that is too high for you, then that's when you start seeing like some side effects like the extra gain weight. You can have high blood pressure and some other side effects that it produces a different disease that is called Cushing's.
What are ways that we as ALD families and advocates are needed to help move our cause forward?
Great question. Stumped him.
Well, I'd say everybody getting involved and advocating for what they think is important, and they're observing in their life and in their experience of the disease, and highlighting that and bringing this forward. And I think all of the people here are probably already actively doing that. But thinking about how all of us as a community can help raise awareness around those questions is probably the single most common thing in my mind. How we then manage and solve some of the issues that we encounter, how much we agree or disagree, that's separate and comes down later in the process. But raising awareness and becoming an advocate for the importance of our experiences, I think, is the single most important thing.
I would just add that if you live in a state that doesn't have newborn screening, that is the most important thing that you can advocate for. Write your legislators, whoever, TV channels, try to push for it. Especially if you live in Maryland, because there is a law that they're supposed to do it and they're not doing it.
That would be amazing. At that note, it is 5 p.m., so I'm going to have to cut off the questions. But for all other questions, you can refer to the website aldconnect.org, especially those that are online that didn't get their questions answered, rather. Let's give a round of applause for the panel.